Yeah, we are live, right?
Yes, sir, we're live. We can start. Good evening.
So welcome all dignitaries, esteemed faculties, and dear delegates on a very good welcome evening. And I, Kuti Krishnan, on behalf of Gennova, would like and the entire team of Gennova would like to welcome you for this scientific event, which is a one of the important events which Gennova is conducting every month. So this is bridging a gap between the practical and the theories, particularly in stroke treatment. So first of all, I would like to welcome Dr. 1 minute. I think my screen is not showing. So first of all, I take this opportunity to extend a warm welcome to our respected post coordinator, Dr. Ajit Cherian. Welcome, sir. Professor Sri Chitra Tirunal Institute of Medical Science and Technology, Trivandrum. Dr. Ajit is a distinguished neurologist with special interest in epilepsy, movement disorder, headache, electrophysiology, and clinical neurology. He has over 178 publications in reputed journals with a high index of 23 and I-10 index of 44. Winner of the tournaments of Minds at World Congress of Neurology, Italy 2021 and runner-up Canada 2023. Recipient of prestigious BMJ Asia Award 2015 for excellence in epilepsy care. Awarded the Young Scholar Award at Venice International University, Italy, and Best Paper Award by Neurology India 2014. He was also received fellowship and travel grant from leading international neurologic society across the globe. Thank you, sir, for accepting our request and accepting our request to guide us in this KT program. Welcome, sir, Dr. Ajit Cherian.
Thank you very much. Okay, shall I introduce other people?
Yes, sir.
Okay, so we have a moderator and two young stalwarts with us who will be presenting some interesting cases. I'll just introduce those young Turks. First, I would like to introduce Dr. Vaishak Renuji. He's a neurologist with 5 years of experience, and he did his residency from the Pushpagiri Medical College, and currently he is working as assistant professor at Kolancheri Malangara Orthodox Medical College.
Sir, I did from Trivandrum.
You did from Trivandrum, and
yes.
Currently you are working at Kolancheri, right?
Kolancheri.
Correct. Yeah, that's what I meant. Okay, so and he has got good amount of publication in such a short span of time, and we are looking forward to an exciting case from you. And we also have Dr. Vijay Lakshmi, who is now currently working as assistant professor in the Department of Neurology at Pushpagiri Institute of Medical Sciences. And she did MBBS from Trivandrum and MD from Malappuram MBS Medical College and DM from Pushpagiri Institute. And she has got a good amount of awards and papers in such a short span. And we are looking forward to her her grace and how she has done the intervention of whatever medical management. So we are really looking forward to that also. And to moderate this program, we have Dr. Lena Joseph, and she has completed her DNP course from both the medicine as well as DNP neurology from Kerala Institute of Medical Sciences, and she is currently working in SK Medical College as well as Karakoram Medical College. So welcome, Dr. Lina Jagar, and for moderating the session. So without much ado, I will just go on to our first speaker. I would like to welcome Dr. Vaishak. Over to you.
Thank you, sir. I have a very small case of it. I'll share the slide. My slide is visible also.
Yes, this slide is visible. Carry on.
Yeah. This is a patient actually referred to our hospital from an outside hospital. He presented a history of acute onset weakness of right upper limb and word finding difficulty within 1 hour of onset outside hospital. And there he was in the window period in an MRI plus MR angio, which was basically intracranial angio. And there is no large occlusion and they lies to therapy place outside hospital. And post lysis, he had near complete improvement. He had some word finding errors, but weakness has improved. And this was the initial MRI. I didn't have the angio. Angio actually intracranial only was there. So you can see that there is left in the opercular area. There is a effusion restrictions in the opercular area, and some of the insular area also is there. So it was a left MCA territory infarct, and post lysis he had near complete recovery. There are some word finding errors, but there was no motor weakness. Everything has improved completely. He presented with a 1 hour of symptoms also, sir.
Yeah, we are live, right? Yes, sir, we're live. We can start.
Yeah. Then they had evaluated the 2D echo, which is normal. Necrosal Doppler and Holter, and media Holter was done, which is negative. And he was discharged.
And a very good way.
He was on immunity. He was on
And I
aspirin
believe
plus
on
Doppler.
behalf of Gennova,
And later,
I would like-
around second week of
I
illness,
would
they
like
gave
to
him
welcome
vaccine
you for
because of
this,
right upper limb. And
scientific
he had
Vaishak, can you just hold on for a minute?
event.
Yes.
There is some crosstalk which is happening.
Yeah. This bridging gap between the practical and the theory, particularly in stroke treatment. So first of all, I would like to welcome Dr. I think somebody. Hello.
Lena, I think
RX.
Yes, yes. RX
Or-
events, please check. There is
Check,
some
please.
background noise. RX
Background
events.
noise is coming.
He's repeating the introduction part.
if you can mute all the others except the speaker, that would be fine.
Hope now it is okay, sir. Please check.
Yeah. Yeah. Correct.
Yeah.
Vaishak,
Yeah.
continue. Please continue.
Sorry, sir. Please continue.
So he presented with right side weakness and some word finding errors of ACM, and he was lying from outside hospital. This was the initial MRI, which was done in the outside hospital, shown left insular and opercular area, some small infarcts, and he recovered almost nearly fine. He had some word finding errors, but the weakness completely gone. And they evaluated with the Doppler necrosal Doppler, which is normal, and even which is normal. And he was discharged to home. And he was discharged with pulmonary defects. He was on aspirin plus clopidogrel and Dovastatin. And he had no other comorbidities. And by the second week, he was not a smoker, he was not an alcoholic, he had no history of diabetes, hypertension, no other comorbidities. By the second week, he again had a transient weakness of right upper limb and lower limb with some word finding difficulty, which improved spontaneously within maybe around 5 to 10 minutes, is completely recovered. They went to the same hospital, did a repeat CT. There was no fresh changes. And the antibiotic was changed to aspirin plus ticagrelor because he developed a recurrent stroke while on aspirin plus clopidogrel and basic investigation to normal. And they came for second opinion. So basically, his symptoms were both were from the same vascular territory. It was from the left anterior circulation to the left side. The second symptom also from the same side. So one possibility is a recurrent stroke. And second possibility is because it happened in the early morning. So second possibility can be a small ictal event also can be raised. Again, it is a focal thing. So it was a recurrence of stroke was the first possibility. So initial evaluation was done from outside hospital MRI angio intracranial plus necrosal Doppler, 2D echo Holter, everything was normal. But being the both symptoms happened on the same vascular territory from the left hemisphere. So again, the culprit we thought might be something we are missing in the vessel. So we did a CT angiogram. CT brain plus CT angio was done. And this was the image. And he was having left side disease. So we trace the left side muscles. You can see the neck. Near the carotid bifurcation, you can see a small region of from the carotid bone, some small bulges there. So that is a carotid web which is circulating there. So this carotid web is a rare and which can occur. Especially in pulmonary stroke, around 13% of pulmonary stroke might be attributed to the carotid web. But carotid web is much common in young age people. This patient is around 70 years without any vascular risk factors. So this was a carotid web which was there. So so carotid web is just like it's otherwise known as carotid intimal variant of fibromuscular dysplasia. So this is actually not a practically it is not an FMD. It is a FMD or fibromuscular dysplasia. It's a medial hyperplasia. Here it is intimized hyperplasia, and it is on the posterior wall of the carotid. This small linear membrane will extend. So how it forms the thrombus is basically, if you take this is the carotid web, there is a small area above this carotid web. There is where the blood can pool in. So that can cause thrombus, which happens there, and the thrombus can bifurcate through the IC of the same territory. So again, the clue was there in this patient was this patient had both the symptoms, which happened 2 weeks while he is on antiplatelet. Again, the symptom was from the left hemisphere. So that was why we proceeded with CT angio rather than with MR angio or any other imaging. So it can be missed in sometimes in MR angio. And our angio just taken from Olsen Hospital was basically mainly intracranial. There was the bulb was visible but not that clear. So it might have missed in MR angio. So it is common in younger age group, usually less than 60 years. African American race, female sex incidence has been associated, particularly in those without any other risk factors. In cryptogenic stroke, approximately around 13%. The recurrence of ischemic stroke in those with carotid web is as high as around 59%. So again, this carotid web is a rare entity, and we don't have much case images. Studies are not there. So again, the guidelines is difficult. So this was the DSA which was done. You can see it much clearly on the left side near the bulb, usually just seen just above the bulb bifurcation. There you can see the carotid web. The posterior wall, there is a small from the bulb outpouching is there. It is basically intima, and just above that intima is where thrombus formation happens and embolus will close. So this patient, we did a stenting. This is second image. Is a post stenting. We could revert that outpouching was completely clear of. And because the stenting was in, because he was having recurrent symptoms. And again, carotid web is whether you should go with stenting or you should go with the endarterectomy or whether you should go with the medical management is the question. Whether what to do is a question. So this was an article that came in 2024, where they state that the recurrence of symptomatic carotid webs may be high. The recurrence of stroke is very high with medical management alone. Interventions, while either carotid stenting or endarterectomy, might be safe and effective treatment for prevent future ischemic event. This came, you see, the article was came in 2024. Then this is the European Society of Vascular Surgery 2023 practice guidelines for symptomatic patients with carotid web in whom no other causes of stroke is identified. After detailed neurovascular workup, carotid endarterectomy stenting may be considered as prevent recurrence of stroke. It is to be and this is the latest update from the Vascular Society of 2025. Whether the confusions remain that carotid webs remains undiagnosed many times. Second is symptomatic. We know what to do, but asymptomatic is again like pure guidelines is not there. So this was not a difficult case, but it was. I mean, it's I think second case we had seen here after coming to Palestine. So this was my case.
I think that was a very excellent one because it's not very common that we see carotid web. As you said clearly, very rarely only we might even overlook. Many times we may in fact overlook. We may be looking for a diseased or a plaque rupture or a tandem lesion. We may be looking for a cardioembolic, and only as you have clearly pointed out, judicious eye with a meticulous eye will identify this carotid web. And you have gone through the literature very well. And as you have rightly pointed out, if it is recurring and if you can't find any other real source of any disease, it is either the options are open, either go for an endarterectomy or even go for a stenting. Okay, how is it? Do you have the follow-up of this patient? Now, when was the stenting done? How long a follow-up do you have?
So this was done in 2023, maybe in the June somewhere around. He had came to follow up last month also. He's doing fine. No other symptoms. He's doing fine.
Okay. After the stent, is he on dual antiplatelet?
He's on dual antiplatelet right now.
Same ticagrelor and aspirin.
No, actually, we did the proper resistance assay because negative. So changed to proplet plus aspirin.
Okay, fine. Okay, it was essentially not an antiplatelet drug failure because it's basically the disease process and everything. Okay, good one. Great. Dr. Lena, do you want to comment something?
Thank you, sir. Dr. Basha, it was an excellent presentation. I would like to know whether carotid Doppler has pickup rates in carotid Doppler in carotid.
Actually, when I go to the articles, as well as
Actually, I'm not able to hear your voice.
Yeah, hello, am I audible?
Yeah.
When I go to the articles, it is written that even MR angiogram, because when it is a TOF MRI, you can miss it, and even carotid Doppler is high. It's very objectivity is much less in carotid Doppler, so it can be missed. Only if they are searching for it, it can be missed. So CT angio or DSA is the best method. Especially CT angio is the best tool they are suggesting for if you are suspecting a carotid Doppler. First CT angio, then for DSA suspicion.
Oh. So the pickup rates for carotid Doppler is a bit on the lower side. You definitely have to go for a CT angio and followed by a DSA. So that will be the ideal one to pick it up. So that's the thing. Okay. If there are no further comments, shall we go to the second piece?
Yeah,
Dr.
okay, sir.
Vijay?
And in the comment section questions, we'll take it in the last.
Okay, that's fine. Do you have any questions in the comment section?
No, sir.
Okay, fine.
No, sir, not currently.
This is Dr. Vijay Lakshmi, analyzing stalwart from Pushpagiri Medical College, who is working as an assistant professor at Pushpagiri Medical College, and she has titled the Countless Obstacles Still Prevail. Okay, over to you.
Good evening, Ajit sir, Lena madam, and others. This is a very simple case, straightforward case where we did an IV thrombolysis. It's a very simple case, but the hurdles which we had make it different in my case. So we'll start with the case.
Okay.
So this is the story of a 44-year-old male hailing from Rani, right-handed, bank manager by profession. He presented to our emergency department with acute onset right-sided weakness of 3 hours duration. He was taken to the hospital by bank staff. He also had a fall after developing weakness, had a hit to his face as well. However, there was no history of LOC, seizures or vomiting. No external injuries or bleeding points were noted by the accompanying people as well. So assessment at ED showed that he had global aphasia, gaze preference to the left side, right hemiplegia, power 1/5 in upper limb and lower limb, right UMN facial palsy. And in the right eye, there was an abrasion in the periorbital area. However, no bleeding, no redness or swelling. So our plan was to take an emergency non-contrast CT because 3 hours are already passed. So we have decided to take a non-contrast CT and it was ordered. And the non-contrast CT showed a dense MCA sign on the left side. So the option for thrombolysis, as he was in the winter period, the option for thrombolysis was given. The possibility of a large infarct, considering the high NIHSS score, dense MCA sign, gaze preference to the left, was considered, and it was very well explained to the relatives. However, the decision was delayed because he was taken by his friends. His wife reached 30 minutes later, and she also had to decide whether to lyse or not. So we got the informed written consent was obtained only after 4 hours 15 minutes of starting the symptoms. So we did the IV thrombolysis with weight-based tenectase. Post-lysis, the status was stable and he was shifted to the intensive care unit. All was good for the first 30 minutes. He showed signs of improvement. Power became 3/5. He could comprehend something, could mutter also. He was hemodynamically stable also. At about 1 hour, I got a call from ICU saying that he developed a right-sided ptosis. So when I examined, it was like significant periorbital edema causing a mechanical ptosis. However, he was hemodynamically stable and there was no NIHSS drop as well. Emergency CT and ophthalmology opinion was planned. So this is the CT taken second. We can see some hyperintensities. So some hyperintensity in the periorbital area on the right side. So there was a periorbital edema. So emergency ophthalmology opinion was sought and a lateral calosotomy with draining was done. Post-procedure, vitals were stable. 4 hours later, he had an episode of epistaxis, but there was no drop in NIHSS. He was hemodynamically stable also. ENT opinion taken, managed conservatively with nasal packing. Again, after 5 hours, there was an episode of hematemesis. This time, BP dropped to 110 by 70 millimeters of mercury. Emergency gastroenterology, medical gastro opinion was taken, and an emergency endoscopy was also done. It showed gastritis only. Conservative management was planned with IV pantoprazole and like that. He was on the way to shifting to the ICU. He threw an episode of generalized tonic-clonic seizure. IV lorazepam and loading dose of levetiracetam were given. After stabilization, when we checked, it was like the NIHSS drop was there by 2 points. So MRI brain with MR angiogram. Previously, we had taken only non-contrast CT. So MRI brain with MR angiogram was taken. So this is the MRI brain images. So it's a diffusion, flare, and susceptibility weighted images showing an infarct mainly in the basal ganglia with extension to the insular area, some temporal, some parietal, and corona radiata with a hemorrhagic transformation in the left lentiform nucleus. And this was the MR angio. It was like after M1, there was an area of reduced flow enhancement, which is seen till this segment. And after that, it is clear. And there was paucity of the distal branches of the MCA also. He was started on anti-edema measures. So after 48 hours, NIHSS improved. He was able to comprehend almost fully. Fluency improved. Power became 3 by 5. In fact, he made a very good recovery. So the tempest was still not over. He started having fever spikes and there was a dip in sensorium. X-ray just showed a right lower lobe patch. And the total count was 16,000 with predominant polymorphonuclear leukocytosis. Procalcitonin was 6. He was diagnosed to have aspiration pneumonia and was started on empirical antibiotics and later changed to culture-sensitive antibiotics. So the treatment was like single antiplatelet statin, anti-edema measures, neuroprotectives, antibiotics, physiotherapy, and other supportive measures. He showed a drastic improvement. Sensorium improved, febrile, FACA significantly improved. Power became 4 by 5. Simultaneously, since he was a 44-year-old with no comorbidities, a workup for end stroke was done. His hemoglobin was 14.6, HbA1c 5.5, triglyceride 110, LDL 102, ECG was normal, echo was normal, Holter showed no arrhythmia. Serum homocysteine level was normal, lupus anticoagulant negative, APLA negative, antithrombin normal. D-dimer was negative, factor V laden mutation not detected, prothrombin mutation also not detected. Protein C activity was 127%, which was normal. Whereas the protein S activity was reduced. It was 29.4, where the normal was 50 to 150. So he was diagnosed to have protein S deficiency. Usually this protein S deficiency is usually associated with DVT, pulmonary embolism also, but it can also cause arterial strokes and it can be a cause for recurrent strokes as well. So the story has a happy ending. At the time of discharge, despite all these complications, he was discharged with a modified Rankin score of 1. So 1 month follow-up, we started him on oral anticoagulation, considering his protein S deficiency. Now also he's under our follow-up and on oral anticoagulation. So the thoughts which I have is like, what is the, can we initiate thrombolytic therapy in a minor non-sinister looking trauma? Here we had just an abrasion, which was looking like a non-sinister one. So I decided to proceed with the thrombolysis. Even though the complication has occurred, we could manage it in time. There was no visual compromise or any other problem. Like that, the benefit of IV thrombolysis appears to be more, even in the setting of complications like epistaxis, hematemesis, and like that. So I think there is a good patient outcome, even with the multitude of complications, that too in a major stroke. After this, we were more daring to do thrombolysis after this. Initially, in this case, we were a bit upset because he was a relative of our politician, and he used to call us daily. Me and Regis he used to call. He didn't allow us to sleep also. He was telling epistaxis. When they look, it is like lots of complications. But even in that big stroke, the outcome was very good. MRS 1 with such a great NIHSS stroke. So I think it is justifiable to give thrombolysis if it is a non-sinister looking trauma. Thank you, sir.
Good case, very good case, Dr. Vijayalakshmi. You told that the ophthalmologist came and did a procedure, something called
Lateral callosotomy.
What is that? What is that
Just-
procedure?
Just put an incision just below the area and just drained out. That's all.
Okay.
There was no other complication. It was done overnight itself.
Okay, good. Yeah. Anyway, it looks fine when things come out well.
Yes, otherwise it will become a big problem if something would have happened. But I think the good result, or we can see some chorithrombosis, some stenotic area in that angio, maybe recanalized or distal, there was positive, but there was an area where there was reduced flow enhancement. Might be a thrombus after M1.
Agree. But
It has
then
to be a bad stroke, actually.
it's a
There
bad
was
stroke. Definitely, whenever you have a dense
dense
MCS
MCS sign itself, and the
then-
NIHSS also was very high. So it was definitely a bad stroke, but we proceeded with thrombolysis, and the MRS was really, we were very happy with the MRS. At the end of 2 weeks, it was like 1.
Okay. I would like to congratulate the ophthalmologist because within 4 hours of
They
doing a
came
thrombolytic
and did
therapy, you have done a procedure. So no, I don't think anybody else would dare to do a procedure.
definitely.
After
I have
within 4
started
hours.
doing thrombolysis only, and this is about 2 or 3 cases I have done only. Then at that night, he came by the evening, night, lots of complications. Even I didn't allow Regisar to sleep because I was calling him because I did this, it is now like this. But emergency ophthalmology consultation was given, even the MO came actually. She came. I like to congratulate her also for coming and doing it. Very easily, she has done that and went.
Because even if you put a small incision, it can become a bloody battlefield. It
At
can
that
become
time,
get out
what
of
I was
sight.
thinking was like, he will lose vision with compression to optic nerve or something like that. I'll be held responsible. A lot of politician calling. So I was very apprehensive, but everything turned out to be good.
And then within 5 hours, you made him undergo another procedure, OGD-scopy.
OGD scopy. Ramesh sir was there. He know actually. Now he's in Marsliva. He was there. He came in the morning itself, did it first. I was calling, sir, please come. Will you do this? I don't know whether what is happening. Patient is very influential. I don't know what will happen. He came. He also came and did it as the first case itself. So they were very supportive. All the specialties, they were very supportive. And the critical care team, emergency team, everyone.
When did you start the anticoagulation, by the way? We would have started it
After 1
soon.
month. 1 month, sir. After 1 month visit.
Why that
we
1 month
started.
period?
Since
You were
being
waiting for the
and all,
reports,
I
blood
thought,
reports to come or what?
no. We actually got it 2 weeks. After 2 weeks, we got it actually. We started only after seeing that hemorrhagic transformation. I thought we'll delay it. Now
Okay.
also he's in, sir, actually, what is the recommendation of anticoagulation in protein S deficiency? I have read like that we will repeat protein S after stopping anticoagulant. If it is coming to normal, we can stop. Or
But
we should
currently,
continue.
he is not on any vitamin K dependent anticoagulants, right?
Yes.
So at the moment, like this is de novo their side, because you have a stroke, you really don't have any other etiological factors other than this proteinous deficiency. You are
So we
justified
have
in
to
starting
continue
straight
like
away.
that.
Yeah.
Right
correct.
now we
Yes,
have to continue.
yeah, it's a
But I-
major event and you will have to continue for that.
Sir, I have a doubt, sir. Sir,
Yeah.
in acute scenario, should we send proteins now or after? Acute
Actually,
scenario-
there's a problem in your audio, boy. I'm not able to hear you. I think
Sir,
that will-
I'm audible, sir. I'm audible, sir.
in between it's getting broken.
I think network issue.
Hmm.
Sir, in acute scenario, should you send proteins or wait for 2 or 3 weeks to send a proteins in acute after acute stroke?
Okay, that's a nice question. But I really don't think, will the acute scenario change the levels?
Whether
I'm not very sure.
whether the sample was taken before anticoagulation, or usually Matthew Thomas sir used to say on the protein CNS, always you have to go before. I don't know
So-
whether thrombolytic agent also has a.
So when I read
Yes.
through CVT and all, when I read through,
Yes.
in acute scenario, proteins can be low, so you have to wait for acute scenario for and proteins and proteins.
Okay. You mean that once the acute stress period is over, you need
Yeah.
to do one more sample?
Yes, sir.
Okay, fine. Maybe a week apart?
What they're telling is 2 to 4 weeks is what I remember.
2 to 4 weeks. Okay, good. That's a nice learning point.
So there are few questions from the audience.
There are a few questions.
Yes, sir.
Oh, carry on.
So the first question is by Mr. Shrijit. He is saying it's for the second case. Did we do reverse before eye surgery?
No, nothing was done.
Nothing was done.
Nothing was done.
Okay. And the second question is 24 hours of after TNK, LMWH was given or not?
This is regarding the second case, right?
Yes, sir.
No, we haven't heparinized. We have started the anticoagulation only after 1 month.
Because immediately post procedure, the etiology was not very clear because they could not find an etiology in the immediate.
We
Post-
got the report by 2 weeks only. After
2 weeks away, because whenever we give for a thrombophilia workup, we get the report over 7 or 10 days away. Correct.
So these were the only two questions.
Okay. So I would like to congratulate both Baishak and Dr. Vijayalakshmi. It was both cases were quite interesting, and I benefited by listening to both of you. Leonard, do you like to contribute something? Like, would you like to add something?
Yeah, both the cases were really good. Excellent cases. And the first case was really, we learned that we have to evaluate it on carotid web also. And regarding the second case, it's a usual thrombolytic journey sometimes, which turns into a hard path. I just have one question in the second case. Have you sent ANA profile and
Yes, it
viral
was negative. Negative. Everything
negative? And what about VDRL? Because I had
We haven't
seen
said
few
actually.
syphilis cases with this negative,
Like-
right? And hematology opinion was sought.
No, madam, it was not taken.
It's a very beautiful case.
Thank you.
Regarding the second case, like usual in our setting, many a time we may in fact take for a mechanical thrombectomy because when the clot load is too high, the thrombus load is too high, your chemical is not going to be really effective. So we might as well go ahead with a mechanical thrombectomy when you have a T occlusion or this kind of a long M1 occlusion. So that's what we often do.
We actually gave option for them. They didn't
Okay.
went. Actually, we have given option either to Amrita or to
Okay.
Srijitra. We have given option.
Okay, got it.
There is one question which has just come up. It's for the second case. What was the serum fibrinogen level after 24 hours of TNK?
Actually, we haven't checked that.
I don't
Do you
think
routinely check it?
No, sir.
No, we don't do that actually.
it's not easy to get. I don't know whether it's available to get that much time limit.
Yeah, Kalpita, any more questions?
No, sir, that's it. These were all the questions.
Okay, so shall we wind this up?
Yes, sir. So your closing comments and we can wind up.
Yeah. I'll just summarize by telling what I learned from these two cases. From the first cases, carotid web is something which we often overlook. Like you really need to be on the lookout for carotid web, and Doppler or carotid Doppler will be a poor investigative modality. You have to go for a CT angio followed by a DSA, and you have to hunt for it. You have to specifically look for it, and unless and otherwise, if you don't do that, you are more likely to miss it. And thank you, Baishak, for that wonderful case. And the second case, despite not being in the best of centers, I don't like, there's no offense meant, but then being in such a center also, like, you did the best possible despite so much of hurdles. Things came out really well, and kudos to you and your team for, in fact, kudos to the ophthalmologist for doing a procedure so late at night within 4 hours of the thrombolysis, and to the gastroenterologist for doing an endoscopy within 5 hours of a thrombolysis. I don't think in our place we could ever get it done like that, such a short period of time. And finally, things have come out well. And thanks for that interesting case, Dr. Vijayanesh. And thanks, one and all.
So, thank you, Doctor. And I would like to extend my heartfelt gratitude from the Gennova team to all, Dr. Ajit, Dr. Lena, Dr. Vijayalakshmi, and Dr. Baisak for a wonderful case. And I hope everybody has got a very interesting and a very practical case. Thank you and good night all.
Thank you.
Thank you.
Thank you so much.
Thank you, everyone.